Awesome. Okay, it's 7 o'clock.
All right, well, I think we're going to go ahead and begin. Welcome, everyone. My name is Allison Kuntz, and I'm with LMH Health. And we are very thankful to be partnering with the library to bring this wonderful panel to you this evening. I have some partners who I've been working with on this project. I'm going to go ahead and let them introduce themselves, and then we'll introduce our panel. Janet,
Hi. Yeah, hello. My name is Jana Wallen. I work at LMH in the Poly department and help out with the opioid stewardship team. And this is a project that we've been wanting to do for some time to reach out to the community and have some discussion about opioid use and misuse in our community. And we pulled together some team members from the hospital to talk to the community about this important topic. So we're so happy that you're all here to enjoy listening to some great conversation. So we're just going to go around, and we have 5 panelists that are going to be answering some questions, and we'll get started with them introducing themselves. So Kyle, do you want to go first? Let's see. We'll start with Dr. Harper.
All right, thanks, Jana. My name is Patrick Harper. I originally grew up in a small town in rural Kansas and did my undergrad and medical school training at University of Kansas before going on and pursuing my anesthesia residency at Mayo Clinic in Rochester. And then I stayed on and did an additional year of training for fellowship in pain medicine, also at Mayo Clinic. And excited to be back here at Lawrence Memorial. I'm part of Lawrence Pain Specialists and doing interventional pain medicine, and excited to kind of discuss our opioid use in the community and how it can affect all of us, and then also some of the alternatives we have for these painful conditions.
Okay, Dr. Scarbrough?
Yeah, I'm Marc Scarbrough. My medical background, I went to KU Med. I grew up in Wichita, went to K-State, then KU Med, and did a residency in internal medicine and pediatrics in Kansas City. I've been a hospitalist here, which is acute care inpatient adult medicine here at Lawrence Memorial since 2006. I'm also board certified in clinical informatics, which is a branch of preventive medicine, and I'm currently a trustee on the hospital board, among other things.
Okay, and we have Kevin Joles from our Douglas County EMS.
Kevin Joles, Division Chief of EMS with Lawrence Douglas County Fire Medical. This is my 25th year in the fire service. Hard to believe that, but it's true. And appreciate the offer to be here.
And then we have Kyle, who got kicked off a little bit earlier, and he's back on joining us.
Hello, I'm Kyle Eichelberger. I'm one of the pharmacists at LMH, and I've been chairing the Opioid Stewardship Committee for the past 3 or 4 years now. Feels longer, but I think it was just 3 years. And yeah, we've done some great things with the hospital, and I appreciate Jana's help along the way with that.
And then we have Dr. Foster, who's joined us today, one of our primary care physicians. Dr. Foster, can you introduce yourself? And you might be on mute. Okay. Well, hopefully we'll get him to introduce himself here pretty soon. And let me make sure that he can, see us. Okay.
Just so for the participants, yeah, Dr. Foster is one of our newer primary care providers in Tonganoxie. He's a family physician, and he, like myself and a few of the other providers, have our X waiver, which means that we have gone through the training to prescribe medication-assisted therapy for opioid use disorder. So he's one of our, we don't have a lot of physicians, frankly, in the community that have that training. So I'm so happy that Dr. Foster could at least be available to participate.
Great. Allison, did you have a few announcements before we get started on some of the questions in terms of the format if people wanted to chat in on questions?
Sure. So as we go through, anyone who has joined us this evening, if you want to ask a question to us, you can put that in the question and answer section. That's going to be found at the bottom of your screen. You can kind of take your cursor over the bottom and there'll be a Q&A, and that is where you can just send us questions that will relate to the panelists. So please use that function as you would like. We did have some questions that came in previously, so we're going to go ahead and kind of jump into some of those. And also just to let everyone know who is joining us that this is going to be recorded. So if there's anything you wanted to take notes on or grab, you will have the opportunity to see that later as well on both the LMH Health website and the Lawrence Public Library website. All right. Well, with that, oh, sorry, Janie, go ahead.
Go ahead. No, I was just going to tell, I think Alice and I are going to pull our videos off, so you'll just have the panelists, and then we'll ask the questions as we go. But yes, feel free to jump in with any questions you may have. Okay. So with that, we'll go ahead and get started. And one of the questions that came in that I thought was a really interesting one is, we were talking about what a typical patient would look like who's being treated for opioid addiction or pain medicine. And so Dr. Harper, I was hoping you could lead us off on that discussion about, what would a typical patient look like who either had addiction to pain medicine or had an opioid addiction in your line of work, in your care?
I think that's an interesting question, Jana. I mean, honestly, I think the simplest answer is there is no set patient. I mean, this can affect anybody, honestly. It's something that, addiction can be affecting people of any socioeconomic class, any education, anything at all. And so there isn't a good way of saying that, there's a certain person or anything like that. I mean, there's case reports of people becoming addicted to opioids just off of, one administration. Now, part of this is a little bit dependent upon different risk factors associated with addiction. We know there's a strong genetic component to it, but it honestly can affect anybody, young, old, any background at all. And so I think that's one of the reasons why we just need to be cognizant of that possibility and be aware of looking for some of the telltale signs.
Okay. When you're working with patients, what would you say is the biggest side effect of taking the opioids?
There's a lot of opioid side effects that I like to discuss with my patients. There's the more kind of straightforward side effects such as constipation that can occur, respiratory depression, meaning that they decrease the brain's desire to breathe and slows down breathing. And that can be made a lot worse if you take them in conjunction or with other medicines like benzodiazepines such as Valium, Ativan, things like that, or alcohol can also really increase that risk, and as well as some other sedating medicines. They can cause sedation. They can cause nausea and vomiting, itching at times. And so those are all kind of a lot of the side effects that you can expect in that regard. But there's other things that can cause also. At some points, opioids can actually make pain worse. There's something that's called opioid-induced hyperalgesia, where actually sometimes the opioids themselves can cause the body to actually feel like they're sensing more pain and can increase pain. Can also lower testosterone levels in men is another side effect. And then there's always that risk of addiction. but there's also something that everybody ends up developing is dependence and tolerance to the medication, which is, something completely different. But I think some people have a little different view or seem like dependence and addiction might be a similar thing. I think that was one of the other questions that we had gotten, was trying to explain the difference between addiction and dependence. And this is something I like to talk to my patients quite a bit about, because there is a stigma about addiction, or people will say, you know what, I'm worried I'm going to get addicted to this, or I stop taking this every now and then so I can prove I'm not addicted. And I think as important as addiction is to recognize so we can treat it appropriately, I think also explaining that people will become dependent on medications is just as important as well. And so the way I explain it is, dependence is basically the body becomes used to that medicine. That means that if you've taken it for a long enough time, then your body gets used to it. And if you stop taking it, it goes through some sort of a withdrawal syndrome. And that's essentially dependence. It's more of a physical dependence on the medication. Versus addiction is where people have a craving to try to help continue using the medication, even though that might cause harm. And this could be harm in their personal life, in their professional life. It could be they're having trouble finding money to pay for it, but they're still wanting to use the medication, and that's more of an addiction side of things. And that's, both of those things are different than tolerance, which is when, if you use a medicine for long enough periods of time, eventually that same level of medicine doesn't provide the same level of effect at that same dose. And you require additional doses to try to get the same effect. So those are three kind of things that I like to always talk about when I also discuss side effects of opioids. I might have missed something in there too. I don't know if Kyle or Dr. Scarbrough, if you want to jump in, or Kevin.
Would anybody want to jump in on kind of how long a person should reasonably be on opioids?
I can definitely comment on our practice patterns and prescribing patterns that we have really tried to pay more attention to. I think that when you're on opioids longer than 5 days, you start to increase your risk for becoming more dependent on them. And it can be, maybe a combination of, if somebody's in pain, and you are asking for pain medicine, that doesn't mean you're addicted to it. It means you like not being in pain. But when you get past that 5 days, the risk for being on opiates or taking opiates on a relatively regular basis within a year are much higher. So when we're discharging people from the hospital, for example, let's say you've had an injury, maybe you've broken a hip, or whatever you're recovering from surgery, we're making a very concerted effort to not prescribe more than 5 days potentially, and to use other modalities so we can treat that pain and deal with it. And we definitely are more, in general, when folks have chronic pain, which is quite common, to really focus on functional status and not pain. The likelihood that we're going to make your pain go away is pretty low, but the likelihood that we can help treat you such that you're more functional, is really our much higher goal. The problem with the opiates is we all make natural endogenous substances that give you that feeling of euphoria or well-being. And so you might say people are addicted to exercise, or whatever might make them feel good. They're addicted to being on the stage because they love acting or singing or whatever, and they really like that natural feeling of a natural high. And unfortunately, there's a lot of things besides things that are good for us that can make that feeling. So someone might say, I'm not really addicted to it. I just like, it just feels so good when I do that. But actually, that's the path towards the pathological actions that one might take to get those. So that's a long way of saying we try to prescribe less than 5 days of opiates at a time. And really, I think part of that education from folks like Dr. Harper, and whether it may be your surgeon or your practitioner, maybe in the ER, the reason that they're trying to stay under 5 days is that seems to be kind of a magical time when you increase your risk for being on them long term.
Yeah, I think that's a really good point, Mark. And that's something when I was in training, we were looking at a little bit and looked at several of the different surgeries. And we kind of grouped what we decided was the 20 most painful procedures and looked at the opioid prescribings for discharge that were occurring during those times, and found that things were just all over the board. As far as the number of prescriptions and number of tablets and everything else. And so it kind of sat down and came up, everybody came and had their own little work group and came up with what they thought would be a reasonable amount, and kind of going along with the CDC guidelines of 3 to 7 days as kind of being the ideal area that, hopefully you don't necessarily need more. And ended up cutting back because, just like you were saying, that there's a big correlation to continued opioid use at 1 year and 3 years based off of that initial prescription, the size, the number of tablets in the initial prescription, as well as the number of refills. And it's interesting, they ended up finding out that they cut way back on how many tablets were going out the door after a surgery. They weren't getting phone calls from the patients saying, I need a refill. Patients were still happy with their analgesic regimen, so their amount of pain relief, they were still happy with that. And so it was an interesting take to see how we can kind of scale some of that back without causing any harm to patients that are needing some of these medications to help recover after a surgery.
Yeah, I'd also mention that we've kind of done that with a lot of our joint surgeries at the hospital. We've implemented what we call multimodal ways of managing patients' medication or pain medications. So we've been utilizing non-opioids as much as we can with scheduled Tylenol or anti-inflammatories such as meloxicam or Celebrex. So we can hopefully reduce down those amount of opioids that we end up having to send patients out with, in turn also reducing down their risk of becoming addicted. We also have that discussion with patients as they're going home, because they are, after joint surgery, being sent home with probably a decent amount of medications that they may not necessarily need. So we also have that discussion about how to take it if you're in pain, but tapering off over a certain period of time, just to lower that risk, and using it when you need it, but then also finding where that point is where you can cut back on it. So I think that's kind of been our goal with a lot of surgery patients too, is trying to lower that risk.
So there's definitely, as we've heard, some benefits to this, because as was brought up, nobody likes to be in pain. So there are some reasons that we definitely need these. But what are some of maybe the side effects or things really to look for when you might be noticing a patient who maybe is developing a dependence or an addiction?
Well, I mean, I think, dependence is just something we all get, right, over time. Developing an addiction, it's hard because there's no good monitor for pain. You can't put a little probe on the finger and then it pops up and says your pain level is 8. And so there's a lot of that has to be communicated from the patient. And I know I've had some patients I've talked to that just don't feel like they've been heard of how much pain they're having. But at the same time, we need to be monitoring that and being careful about how much is doses are being escalated and things like that. I think that if people are starting to lose their prescription a lot, or if their loved ones are noticing some really aberrant behavior and they're just not acting like themselves, usually that's, I would say, probably the first thing as far as what people are how people are kind of figuring out something's wrong, is a lot of times it's a loved one, it's a family member or a very close friend that just notices, something's really off, and not really understanding what it is can be difficult to pin down sometimes.
And that kind of brings us to this other question about family members, because I think there's been a lot of conversation regarding the safety of family members when you have a loved one in your home taking opiates, or you have children in your home, or you have lots of risk factors, especially maybe with high school athletes who are injured and on opioids. And so I'd like to throw out that question, that conversation about how to keep our loved ones safe during this time, during that, and how do we handle if it is a epidemic of high school athletes who are becoming possibly addicted to opioids during injuries. Does anyone have any thoughts on that?
I do think that the younger folks may be more susceptible to addiction. I think that in general, I think the medical community is well aware of, our concern not to get folks to, to be addicted, to become addicted. If somebody has a severe injury, like a broken leg, or if they have a surgery, I think we all want to treat pain and make that be bearable. But I think we're generally very cautious for prescribing opiates for, again, longer than maybe even a few days at a time. And if someone is on, prescribing opiates to anybody for perhaps sprains or sports injuries is really, we're in the high school arena, I'd be very concerned if any practitioners are doing that in general. I mean, ibuprofen and Tylenol, or, non-steroidals have been proven very commonly for Tylenol to be as effective as opiates for treating pain. And, things like topical treatments or compression or icing or whatever, other modalities, I think are definitely the norm. I don't know, and Patrick, you may have more experience, or Dr. Foster, but I had a friend recently who in college, played college football, who passed away recently, probably related to opioids. And that may be where, folks, if they get injured quite frequently, or they are expected to perform, with a lot higher pressure, I think that does set kids up perhaps where they've been injured and they're, a star player, or if they're a scholarship athlete, or, obviously professional athletes, you get into a lot more pressure there, where the pressure to perform despite pain might drive folks to, go down that path, either with their physicians or, getting it from other means. So I don't know statistics on high school students specifically, but I would say, if anybody's prescribing opiates to high school students in general, I think I'd be very concerned about that in general. But again, it's not necessarily my area of expertise in my daily practice, but if I heard about that, I'd be quite concerned.
I'd piggyback on that. And sorry, this is Dr. Foster here, Jason Foster. I had some audio issues earlier, but piggybacking on that comment, I wouldn't feel comfortable in many situations in the high school sort of demographic in terms of opioid prescription. That needs to be done very cautiously. What we do have, though, in terms of the sort of general risk factors for who would become more likely to become dependent, or I guess to say addicted eventually. We have some tools we can use. In fact, there's one called the opioid risk tool that kind of takes into account history of mental health issues like depression, age, gender, and family history, and any previous substance abuse history. All those things are sort of taken into an account for a sort of gestalt for who is higher risk and who should probably not be getting opioid prescriptions. And I guess I'd say that's kind of part of the practice that I try to employ is, who is more likely to be at risk here, which it does include, if I remember correctly, that starts at around age 16 is in that scoring algorithm. That's what I would say basically in terms of the kind of higher risk.
Yeah, I agree. And with that opioid risk tool, like Dr. Foster was talking about, I mean, some of the biggest points that you can get on that are personal or family history of substance abuse, be it illicit substances, alcohol, or prescription. And, I think that definitely plays a big role in it. And I agree kind of what Marc was saying, that prescribing for sprains in high school age, I don't think that would necessarily be a good common practice anymore. There's been a lot of change over the last 20 years, 30 years on prescribing practices. That there's a lot of good books out there if anybody's interested in. They can explain it a lot more eloquently than I can. Yeah, I agree. And as far as that question on how do we keep people safe, that's one thing, especially if I have somebody I'm prescribing to that they have small children in the house. I'm like, you have to keep these locked up. Like, you have to keep them locked up. I mean, people can die from these, and you have to treat it like any other dangerous item.
So
Yeah, I agree with that. Also, we emphasize that when we're talking to patients about opioids is keeping it locked up, and if you're not using it, if you're done with the pain medication, don't keep it in your closet. And there's a survey Douglas County survey to, I believe it's high school kids and college kids, and majority of patients or kids who had the opioids, they were getting them from family members or relatives. They found them in the drug cabinets and stuff that wasn't being used. So just, even though you're not using them, get rid of them or lock them up and get rid of them the best you can. It's something we always recommend.
Which, Kyle, kind of brings me to the question about our Medsafe program and disposal. Can you tell the community about that we have for safe disposals?
Yeah, we partnered with the Douglas County Health Department and DECA, and they provided us with a couple of grants, and we have Medsafe disposal bin at the LMH Hospital in Dr. Harper's office, and we're in the process of getting one set up at the West Campus near the Jayhawk Pharmacy there. So we've been trying to emphasize to patients and anybody who listens to, if they have any medications left over, to get rid of those, to bring them back to a safe place to dispose of them. And it's not just controlled substances. We'll take any kind of medications that may be laying around, but we always try to focus on those controlled substances, the pain medications or benzo medications that can sedate people and are the highest risk. We also got a grant from DECA and the health department to get these Deterra bags. They're little individual bags that we can send home with patients. And I'll have a discussion with our surgery patients frequently that we prescribed you, 50 tablets of this medication. You may not need all of those, but I'm going to send you with this bag just in case, so you can dispose of those medications when you're done. That way they're not sitting around your home, and you have a safe way of getting rid of those. And so the patient's able to put their pills in there, mix it with a little bit of water, shake it up, and it dissolves the medications, and they can throw it in their regular trash, so it can't be used anymore. But there's a lot of other places around town to dispose of medications. I encourage people to look around. There are many pharmacies, the sheriff's department, they all have drop boxes too. So you can even get on Google Maps and type in drug disposal, and it'll show you where the most recent, or where the nearest drug disposal place is. And the DEA website also has that, so you can look that up also. So there's a lot of resources for getting rid of medications. And there's also drug take-back days in October and April. So we have one coming up next month. So important ways to get rid of the meds.
So those are some excellent examples of community resources that we have, and kind of right along that community partnership area. Kevin, would you tell us a little bit about the training that the EMS staff has with opioids and overdoses and kind of what's out there for the community?
Sure. So we have right now we have all AEMTs, which is advanced EMTs and paramedics that work for the fire department and EMS service here in Douglas County. And we're all trained. We have to have CEUs or continuing education hours every year to renew our licenses, 48 hours for advanced EMTs and 60 hours for paramedics. And within that training is formulary discussions, medication discussions, overdose, and whether it's opioid or other toxins. We cover that every year. It's part of our curriculum that we do within the fire department. We also have other platforms that we can just get on at any given time to get continuing education within the fire department. That's we can do that at 2 o'clock in the morning or 2 o'clock at night, just depends, or in the afternoon, just depends on when somebody wants to pick up that extra education. But it is part of our training regimen to educate our folks on opioid use and how to correct those actions if we do come across a patient that's in an overdose situation.
Great. We had a question too. Someone was wondering about Narcan and if that's a resource within the community, if that's given out at all to family members who might have a concern.
We're not able to prescribe medications through the fire department, and we have the ability to deliver Narcan, but we do not give it to patients or to their family members. That would be a physician, their primary care physician that would be the one that would deliver that prescription for them.
And Jenna, I've done that a few times. You know, if I see somebody who's on either higher doses of opioids or taking opioids with that class of medicine we talked about earlier, the benzodiazepines, Ativans, Valiums, that things that make it a little bit higher risk for people that are taking these medications, I'll send in a prescription for the nasal Narcan. And for those of you in the audience who might not know, Narcan is a medicine that can actually, it blocks the receptors that opioids work on. So opioid will affect a part of the body, and this medicine comes in and blocks it so that it can't actually function. And so if people that are overdosing from an opioid, or be it a prescribed opioid or heroin or some of the synthetic fentanyl that's on the street, things like that, this can stop that effect actually pretty darn quickly. And it's available as in a nasal formulation. So I tell people, it's like, you don't need to learn how to use this. The people that live with you need to learn how to use this just in case.
And we've been trying to assess patients more frequently to see those that may be high risk for opioid overdoses, to have that discussion with them about naloxone. And it's not only available as prescription, it can also be picked up at a regular pharmacy. Participating pharmacies are able to dispense it. So if you have a family member who may be in need or you're concerned about, it may be useful to have around. A lot of times insurances will cover it. I went and filled a prescription just to see how much it was. I think our insurance covered it up to $30 or something like that. So it can be kind of expensive without insurance, but there is some other options too. And there's some programs through Narcan, the company who makes it. And I just would encourage people who feel the need that they have a family member or themselves who might be at high risk to look into getting access to that medication.
And Kevin, we did have a question. Someone was curious, how often is EMS dispatched for overdoses in our county?
Sure. So I pulled some data here that I'm looking at. I just did it from September 1st of last year to 375 days, 85 patients with 106 interventions. So that means 106 doses of Narcan were delivered. That doesn't mean that everybody was intended overdose, just means that somebody may have taken too much of their medication. The first dose may be too much sometimes. I think that doctors can agree with that. So they just don't know how it's going to be, how it's going to affect the body the first time they've taken it. And when we go there, if it's unconsciousness that's of unknown origin, we'll usually deliver the Narcan. And one of the good things about Narcan is it's not something we should be pushing or giving to every person because it doesn't do anything to the body. But if if it is not a narcotic overdose, then it will not affect the body in a negative way. So if we are unsure of why this person is not answering our questions, or they're having difficulty breathing, or nearly not breathing, and we push this and it doesn't correct it, then we can count that out as maybe they're not being an overdose of opioid nature, or it's extreme overdose that will take more than one dose. And I'll piggyback just a little bit on who else delivers this medication. Is we've trained all of Douglas County sheriffs and then Lawrence PD as well on Narcan use, and they carry a dose of Narcan on their person every day, and it's twofold. We want them to be able to use it on themselves if they do come into contact with a substance that they're unsure of, that they are getting exposed to, and they start to have some reactions. It is a device that they can deploy on themselves as well as on their partners, and that's the first line of defense if they do get subject to a substance that they're unaware of. And then also, of course, if they come across a patient, and more times, I think we haven't even had any deployments on an officer themselves or a partner, but we have had officers deploy Narcan appropriately on patients that are experiencing overdoses.
Kind of an overarching issue that we're all experiencing right now when the pandemic meets the epidemic, if you will. So how do you, anyone on the panel, how do you see COVID-19 impacting the opioid overdose? Do you see any impact that's had additionally?
Well, I mean, from a pain medicine standpoint, I'll say that especially when in the early phases, when we really had shut down our procedural aspect, there's a lot of people that can benefit from injections or other interventions, procedures that we can do to help treat pain. But we had really, closed everything down at all the guidance. That kind of limits what we're able to do. And so I know personally, I prescribed a fair bit more opioids during that time than I normally would. And I was involved in a few different of our society presentations and webinars and things that was a fairly common topic. Is, we need to be really careful on this, that we're not going to slide back on all this progress we've been making with the opioid epidemic. On top of that, there's a big problem with a psychological impact of the pandemic. I've seen a lot of people that depression, anxiety has gotten a lot worse with this, and depression, anxiety, and chronic pain are three things that just feed off of each other all the time. And either any one of those things can make any of the others worse, and they commonly do. And so, that also makes people's pain levels higher. And, it's probably would take longer than the 20 minutes we have left to kind of go through the whole aspect of what all's involved with pain. It's not as simple as just cutting your finger and saying, ow, that hurts. It's, there's a lot of other aspects that impact people's perception of pain. I'm not saying that pain's in the head, but there's pretty well documented that things can cause people to either have an increased sensitivity to pain or decreased sensitivity to pain. And, depression and anxiety definitely play into that role a little bit as well.
And I'll just briefly state that I completely concur with the increase in anxiety and depression and overall, it seemed like there was maybe some more pain complaints during kind of the beginning and peak of the pandemic. Absolutely, when there was no procedures available, it did become a little bit difficult in terms of how do we manage some of the pain. I will say from primary care standpoint, mostly it was with the pandemic, it was mostly anxiety and depression were worse, which in that case, less of the opioid kind of route of things and benzodiazepines, which plays into all the kind of risk that we talk about, though, when we're talking about opioids. So I do think it had an effect.
And Dr. Scarbrough, as a hospitalist, have you seen that impact your workflow on the floor too, now that we're kind of back to capacity a little bit up on the floor, acutely involved with our acute patients? Have you noticed that?
I don't know that, certainly if we're talking about COVID, that's kind of changed how we do things in the hospital overall. I would say as far as pain, I don't know that I could comment about a change now necessarily. I just know that for a while, folks were putting off coming in for treatments of various kinds, because we had to either close the clinic or they were concerned about, hey, if I go to the hospital, I'm going to catch an infection. I don't want to go to the emergency room. So I know in general, we had a lot of therapy that was necessary and probably could have been more effective because an ounce of prevention is worth a pound of cure, right? So to say, here in Lawrence that we've seen that impact as far as opiate use, I don't know that I could, I don't necessarily think so, but I don't have any good data.
Yeah. Well, I just had this question that came in. I think this is a really interesting one, and most of you could probably speak to this, but opioid contracts, what are they and why do I need one? So I know we've done a lot of work from an opioid stewardship perspective with implementing opioid contracts on our hospital side, but can someone speak to that question in terms of why we have them, the importance of them, and why does everyone need one, or does everyone need one?
Sure, I'll jump on this first, I think, and welcome other people for sure to join in on their perspective. The opioid contract, the way I look at it is it's an important tool that I use to help describe some of these complications or side effects or risks associated with opioids. In addition, it lays out guidelines of what I expect of the patient, but then also what the patient can expect of me as the prescriber. So I'll sit down and the contract I don't like to call it a contract because it's not a legally binding contract or anything like that. I like that we've come up with a controlled substance agreement, which I think is a little bit more appropriate term for it. But I'll sit down and kind of go through with them of, these are the risks, and it outlines known risk factors with or risks of opioid therapy. I go over the things that, this is what I expect of you. I expect that you're not going to be calling for early refills. I expect that you're going to be keeping your medication secured. Things like you're not going to be using them inappropriately or differently from how I'm prescribing. But at the same time, what I am offering to you is that I'll agree to prescribe you safe amounts of these medications and try to keep you safe. I'll be also using other options to try to help treat your pain. If you look at the data for long-term pain relief with opioids for chronic pain, there really isn't that great of data supporting them. There's other options that are possible as well. And so making sure that we're not just doing this, so we're just going to be getting this medicine, but we're going to be doing a broader care approach that implements a lot of different factors. I think some people feel like, oh, this is just a way that if I mess anything up, then you can fire me. Well, I mean, not really. That's not the way I envision that this is the way that it's intended to be used. I think it's more along the lines that if you have this agreement and you discuss it and you sign it, that is a way of documenting that you've had these conversations with patients, which I think is important in today's society, making sure that everybody is aware of the risks and everything else that goes along with prescribing these medications. So that's my long-winded take on that, but take other people's opinions.
I think it goes back to trust but verify. We certainly want to make sure that our patients, they realize that these are, there are no treatments we typically provide that are without risks, and the risk benefit ratio is certainly in there. And we know that there have been people across the spectrum of society who have had these medications affect their lives adversely, and trying to do things that they would have never thought they would do to get these opiates. And so you trust your patients to do the right thing, but also you want to verify that the medicines are going to the right person in the right amount and not too much. And as Dr. Harper also commented, if someone was using more medication and we didn't know it, they can actually be making their pain worse with that hyperalgesia. So it's really, beneficial for everybody involved. So it's part of us providing good care.
I would agree with the safety aspect of it. Just having one provider that you can go to. You're not having a patient going to multiple providers trying to get opioids. You can keep track of that. And a lot of times doctors will be looking at the K-Tracks or that's the program that we can look and see where patients are filling opioids at or who they're getting the opioids from. But there's also contracts for other medications such as stimulants and those benzodiazepine medications that help with anxiety. So I think it's not just opioids, but I think it's just a tool that providers have that help keep people safe and keep track of where the medications are going and being used appropriately.
I like the term agreement as well. I think that communication is really important with high risk medical practices that include both procedures and medicines. So, as physicians, we all took the Hippocratic Oath to do no harm, and this is in a way a form that is in some ways similar to before you get a surgery done. Being aware of the risks and understanding, and I feel in a communication sense, it makes it more real to people when there's a form there that is signed in agreement by all parties involved, and the expectations are clear. When those expectations are clear, I think it does lead to different behaviors.
Yeah, very good points.
Are there some resources that anyone would like to speak to about possibly outpatient services or just things within our community that could help people who do have an opioid addiction?
I would just mention that as a general place to check, SAMHSA website would be a good place to start, I guess, if somebody was looking for treatment options. I got on there today and was looking at what all they provide, and they have a tracker so you can look up and see who has opioid treatment programs near you. You can look and see which kind of providers would provide Suboxone therapy. So that can kind of get you in touch with some providers who might be able to help you. That was one of the places I noticed recently that may help.
Yeah, that's actually, I've used that same website, Kyle, and that's SAMHSA, SAMHSA, which is, I can't remember, Substance Abuse Mental Health Society or something like that.
Yeah.
Service Administration. Yeah.
Oh, the Service Administration. There you go.
And I posted a link from the SAMHSA. The first link I posted there has that a link to their site.
And I don't know if that went to everybody here. I'll send it out to all.
I sent it to all the panelists and attendees. So
Oh, you did?
not
Okay.
everybody, but
Oh, yeah, you did.
everybody who's anybody.
Yeah, so I'll say SAMHSA is a good resource, and I think also your primary care doctor is a good resource. I think there's been enough education and training out there on how to safely reduce opioid prescription amounts, and perhaps someone's not actually going to be able to reach being off opiates completely, but they can be at a safer level. And that's something the primary care physician, wherever you're at, should be able to help you accomplish. At least if a patient is motivated enough to go that route to decrease the risk of how much they're taking, that should be available to them at their primary care.
Dr. Foster, that's a good point. I'd like to know for myself and for everybody. Do you feel like medication-assisted therapy, how far are we from that becoming sort of standard for primary care physicians to provide that?
I think it should be rather close. It is kind of still a gray area in primary care, and there are other gray areas of primary care where we have sort of endemics, or we have threats to population health that primary care is really the suited office for that. And opioid overdose is a problem or endemic to the United States, as are others. So I think it's appropriate. It is very appropriate for it to be in primary care. There are aspects of it that are difficult, though, and there are certain kinds of opiate users, perhaps those who are using non-prescription opiates or other more dangerous opioids like fentanyl that are they're getting illegally, that I think is probably not well suited for primary care. Those are probably better suited for psychiatry and rehab with behavioral health attached, so you have all the resources to be successful. But in a standard primary care setting where it's been opioids prescribed by a physician and have been there for a while, and those should be able to be recognized by primary care. And then in that situation, I think X waiver, which you mentioned earlier, great for as a tool to assist for those who are wanting to do that.
All right. So in the interest of time, I want to make sure everyone gets one last opportunity to just let us know your thoughts. Let us know kind of your takeaway message that you want people who have joined this Zoom this evening really to take away. So if anybody wants to start, and we will just kind of do our closing thoughts, things you want the community to know.
I'll start. I want our community to know that we recognize that pain and the treatment of pain in and of itself, as well as opiate use disorders and addiction disorders, that we know it's a problem, and I think that we are taking steps. I think Patrick Harper being here is one of those steps that we've taken to try and address that in a more comprehensive manner. I think we all know that we're not where we want to be. And, my question to Dr. Foster is part of that. I think we're in that transition of, we used to think that addiction specialists were necessary to provide medication-assisted therapy. But I think that's more and more the physicians who are coming out of primary care residency training are coming out with the expectation and the training that they'll handle that. So we have a lot of great resources for our community, and we recognize it's a problem. We want to get better. So we appreciate everything that Jana and Kyle, especially with the opiate task force here at LMH, are doing, including this here. And I also think that the resources that our administration, that Russ Johnson has put forth toward mental health in particular for the community, I think I commend him and our administration on that focus.
Well, I think that's all good points. And I think with the kind of prevalence of Suboxone or coming out for treatment and the safety profile associated with that compared to previous options such as methadone, I mean, it makes it a lot easier to help maintain somebody on a medication-assisted treatment for addiction. I guess my thoughts are, there's a lot of things that can cause pain. There's a lot of ways to treat pain. Chronic opioid therapy, when we talk about chronic pain, which is pain that's been present for 3 months or longer, doesn't necessarily have the greatest the greatest data behind it. Doesn't mean it doesn't work at all. Some people it's the right therapy, but there's a lot of risks associated with it, and there's a lot of ways that we can try to help prevent those risks or identify those risks. And there's a lot of other options we have to help treat pain as well. And so, I think that we're going to, like Marc was saying, we're trying to continue to build some of these resources. And I think that's for the community is something that I'm excited for.
I would say I want my takeaway to be that hopefully patients realize that I hope we can decrease the stigma of opioid use disorder. I feel like there's a lot surrounding patients who may have addiction issues with whether it be opioids or anything. That it's something that happens. It's not some kind of character flaw or anything like that. That these things happen. That patients can come to LMH and get help, and also want the community to know that we're, as a health system, LMH Health System, we're doing our best to combat the opioid epidemic. Trying to do safer prescribing, alternative to opioids, to help treat pain, and increase in our education to patients and providers, increase in our areas for disposal of pain medications so they're not out in the community as much. And then just also improving our data tracking too. I think there's still a lot we don't know about the opioid abuse in our community, even in Douglas County. Douglas County Health Department's done a great job collecting as much information as they can get, but we still don't have a great idea of what some of our greatest areas of needs are. So still trying to improve all that while taking care of the patients.
Kyle, that was well said, and I'll just say that I do think that LMH is definitely kind of ahead of the curve in the community to combat, the issues behind opiates. And again, it is a condition, and it's a condition that
think we lost you there, Dr. Foster. Maybe hold that thought. We'll let Kevin go ahead and maybe share his thoughts with us, and then we'll see if we can get Dr. Foster back.
I just think that it's good for the public to know that there's a great partnership between LMH and LDCFM, and not only in regards to addictions and what happens if we do encounter patients in the field and take them to the hospital, but various different components in healthcare and things like this always help the community realize that we're all here to help. I know this isn't really as deep of a thought but earlier on in the conversation we talked about the age of some of the patients that are maybe being seen. And I know that every patient isn't always seen by the fire department. There are some days that we all feel that we think we saw everybody in the city. But I just drew some numbers real quick, and we only had about 12 patients over a year that were under the age of 21 that would be an opioid case. So there's not a lot, not a prevalence. We are in the Midwest. That doesn't mean that we're immune to any of these addictions, and it's not as prevalent as it is maybe on the East or West Coast, and things travel in waves. But we are prepared, and as well as LMH, and it's good to know that we don't run a lot of these calls. But like I said, that doesn't mean just because we didn't run them, it doesn't happen. So it's good for these conversations to shed a light on what to be prepared for and what to look for. So thank you for the opportunity.
Thank you.
Yeah, sorry about losing that there at the end there. In closing, essentially, I am encouraging people out in the community to continue to seek education, and also to be aware of maybe perhaps a family member that they have a concern for, and to know that LMH is equipped to help that individual. And if they're having concerns, or if they don't yet have the family member as a patient in LMH, that certainly it's a good resource for them to be plugged into.
Excellent.
And I just want to thank everyone. This is Jana again. I just wanted to thank everyone, all the panelists who agreed to to bring your advocacy, your engagement, and your willingness to come forward and have such a great inaugural event. I hope we can continue to do this sort of thing throughout the community, and our opioid stewardship team at LMH is going strong and has lots of exciting things on the horizon. So we are really excited for this event. So thank you all.
As a final reminder, this was recorded, so we will be able to share this on both the Lawrence Public Library, who was a fabulous partner in this, so thank you to them as well, and on the LMH Health website. So thank you again to all of our panelists, and if anyone would like to view it again, you can check out those resources. So thank you so much.
Thanks for having us.
Thank you.
Go Chiefs.
Go Chiefs.
Go